This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
I'm Adam Studley. I'm the director of the UCSF Center for Healthcare Value. And I just wonder, based on what you just heard from Chris, is there anyone who thinks they've had a bad value experience? You got things you didn't need. Is there anyone who thinks that? So those are there are a fair number of you, and that's a getting things you don't need is a way for value to be low. Another way for value to be low is to get things that maybe you did need, but to not have them done right. And that can happen too. Has that happened to anyone in the audience? A fair number of people think they've also experienced not having things done right. Well, we're going to talk about both of those in the next half hour, and then we'll have questions and answers after that. First, one kind of threat to value, and I'm going to make it very concrete. Cataract surgery. Is there anyone here who has had cataract surgery? We got people who've had cataract surgery. How about people who know people who've had cataract surgery? Okay, so everybody. For the people who, either it was you or you know somebody, did they get sort of a pre-op workup to make sure that it was going to be okay to have their cataract surgery? Have you heard of that happening? Yeah? It turns out that that's really common, and yet we've known for more than 20 years that you don't need to do that. So when cataract surgery first started, it was kind of a horrible procedure, certainly horrible from the patient perspective. So a cataract is when the lens in your eye, when the lens in your eye gets hard and dense and you can't see through it as well. And the lens in your eye is right behind the part that you can see. When it gets hard, it's a thing that you can reach in there and grab and pull out. And it's sitting in this kind of pudding kind of stuff. And when we first did it, because it's a big thing that you have to pull out, we had to put people to sleep, because otherwise they'd have to sit there while we tugged on their eyeball, and the thing came out with this kind of horrible sucking kind of sound through a giant slit in their eye. And so nobody wanted that, so we put them to sleep. Putting people to sleep always involves some kind of risk, so we always had anesthesiologists there. And some of those risks are to the heart and to the lungs, and so we worked people up to make sure that it was safe for them to go through that. That is not how cataract surgery has worked for a very long time, though. Nowadays, we've developed technology where we can make a tiny slit about as big as your ballpoint pen, the end of your ballpoint pen, and stick a little probe through it that will liquefy that lens and suck it out very quickly and with very little trauma or anything noticeable even to the patient. And so usually when we put them, when we do this procedure, we don't put them to sleep. We put a few eye drops in so that they can't feel the tiny little slit that's made. And we're done somewhere between 11 and 18 minutes. So basically what we need to know is that you can lie down for 11 to 18 minutes and have someone drop eye drops in your eyes. That's what we need to know if it's safe for you to do the surgery. How many of you go to bed at night? For more than 11 to 18 minutes? And how many of you put in eye drops? Have ever put in eye drops? Okay. Do you feel like you need a doctor to say that that's okay? No. But still we do that in medicine. We've known for 20 years that we don't need to, and still we do. And it turns out if you mess up stuff in cataract surgery, that can really mess up a lot, because lots and lots of people need cataract surgery, and a lot more are going to need it. It is already the most common procedure done in senior citizens, and it's just going to go through the roof. And so if we keep wasting money there, this is your trial that did it in the 1990s. If we keep wasting money there, then we'll waste a lot of money. But no one has done anything about it for a couple of reasons. The first reason is when you think about what tests we do to work you up, we're looking for heart and lung problems like EKGs and chest x-rays, things like that. You can do those for a whole bunch of other reasons. So if I see you getting an EKG, and I'm the insurer or Medicare or whatever, I may not want to run down there and say, stop, don't let that person have an EKG, because you may be getting it for a very good, perhaps even life-threatening reason. So the first thing we have to do is figure out, is there a way we can tell whether or not someone's getting something that they don't need? So how can we do that? Well, this is what we did. What we did was we took a whole bunch of people, 500,000 people, who had cataract surgery and had Medicare insurance. And we looked at them at the point where they had surgery, here. But then we also looked forward and backward. So when we looked backward in time, we asked how many of those procedures that you can get for a lot of different reasons, how many of them did you have in the months leading up to the procedure? And we took the average of that for all these 500,000 patients. So this is the tests graph here. We also asked how many office visits did you have? Because you can have office visits for lots of other reasons rather than getting cleared for surgery. And what we found was that these things are happening all the time. In the 12 months that lead up to having a cataract surgery, people are getting tests and they're getting office visits. But in the 30 days before surgery, you see these two giant spikes in tests and office visits. So yes, it's possible these could be for some other things, but it seems pretty improbable that you would have these giant spikes because of other things that went wrong right before cataract surgery. Doesn't that seem like too big a coincidence to be believed? So based on this, we're pretty sure that there are patients getting more tests than they need, tests they're known not to need. So the next thing we did was ask, well, which doctors are those that are doing it? Because if you want to do something about it, you got to talk to the people who are making the tests happen. What you see here is a graph of doctors. And I want you to try and ignore this thing here, this half, and just look at this. Does this kind of look like a bell-shaped curve to you? Bell-shaped curves happen when there's random variation around some phenomenon. There's a central tendency, a way that sort of people average out to be. But of course, there's some variation in exactly what you're measuring at the particular time. In this case, it turns out that if you look at these slides, tests were happening, and it turned out about 1/3 of patients would get a test every month, before the big spike month. Okay? So what we did was we plotted out the doctors according to what percent of their patients got a test in this month before. And this bell-shaped curve, the peak of it, is right about 1/3 of the patients. So these people are doctors who aren't changing what they're doing. They just have random variation around that number 1/3. Some of them have less and some of them have more, but basically probably how they're thinking is, I don't need to do anything here. And the taller the spike, the more doctors there. Okay? So this group, which actually turns out to be about 3/4 of doctors, are saying, I'm not going to change anything. But that's not all that's on the graph. So you got your bell-shaped curve over there, and then you've got this whole other half of people. And in fact, if we focus right here on people whose patients, 75% or more of their patients, this group here, and you see this huge spike, doctors who every single one of their patients got a test. Turns out this adds up to about 1/4 of the doctors who are probably their pattern, these are probably accidents that they're not 100%. Probably their pattern is tell everyone to get tests. Does that make sense? And you can see that most of the doctors feel like this is where we should be. They know about the studies, and this is what they want to do. And then there are these doctors over here who, as it turns out, can waste an awful lot of society's money. So if you went to these doctors here and you asked them, hey, why are you different from all these other doctors? What do you think they might say?
I'm more careful.
I'm more careful. Anything else?
Our patients are sicker.
My patients are sicker. Both those things, but especially my patients are sicker. My patients are different. So as we're doing this and we want to go out with a message to doctors, we need to be able to address what they're going to think and what they might say back. So what we did was we made models to predict who's going to get a test. And in these models, as you add variables in, what you do is you look at everyone who got a test and everyone who didn't get a test. And you say, my model's better if whatever its prediction is for the chance that someone will get a test is higher for each pair for the person in the pair who got the test. So now we've got 500,000 people, a bunch of them got tests, a bunch of them didn't, and we're hoping that as many people as possible in our model, it's a good model, if more often we predict the chances of getting a test are higher for the person who did compared to the person who didn't. Does that make sense? Okay, so you can draw that out on a curve here. What this curve here shows is this first thing, this straight line at 45 degrees, is what if you're just flipping a coin? So as your probability of predicting the person gets a test goes up, the chances that they go up by about the same amount, about half. So half the people are going to get it if you flip a coin. A perfect test would go right along this axis and right over here. It would cover everybody. It would get it right in everybody. All right? So what you want is to move from this line here as far up to this corner as you can. You want this here. Well, it turns out that if you make a model that uses everything known about the patients, you get this dotted line here. Do they have diabetes? Do they have leukemia? All their conditions, how old they are, all of that. This line is barely different from a coin flip. Okay? So patient characteristics explain almost none of whether or not they get a test. Then we did this model, this one here, and it's much better, you can see, than that model. But it only is built on one question. And the one question was, who is your doctor? So, who is your doctor? Much more important than who are you? Does that make sense? And how sick are you? The second question we asked, or the second model up here, this one that you can just barely see, there's a solid line here, but there's a slight dotted line right there, just underneath the solid line. We added one more variable to that. Who was your doctor? And then we added, did you have an extra office visit to your primary care doctor before the cataract surgery? So that's the mechanism, or part of the mechanism by which you get these tests, is you go to see your doctor at extra time, and this model does even better than just who was your doctor. Then we said, all right, so who was your doctor and did you have an office visit aren't great reasons for getting tests. We need to put back in all the possible reasons and see how much more of the variation they explain. So this last solid line is we put everything back in. We added to this 2-question model all the patient characteristics that were known, and then we added a whole bunch of other stuff, the kitchen sink. We added how many primary care doctors were there in your area, how many ophthalmologists were there in the area, how easy was it to get tests, blah, 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 blah. You can barely tell that there was a different model, right? That little slip of clear space is the only additional benefit by adding in things about patients or where you lived or the resources available in your area. Basically, it comes down to, I get tests based on who my doctor is and whether or not the ophthalmologist schedules a visit with that doctor before I go. Does that make sense? Those are not good reasons for people to have things done. So this is evidence that, let me back up. Unnecessary things are happening. We know which doctors are doing it. And it is not because their patients are sicker. It's probably not because they're more thorough. At least three-quarters of the three-quarters of doctors who aren't doing it wouldn't buy the argument, clearly don't buy the argument that this is a sign of thoroughness. It's just doctor practice pattern, 2 doctor practice patterns. Who am I and does the patient get an extra test? First thing that we're going to say about low-value care, this case in the case of cataract surgery, it happens a lot. You saw too big a hump over here. And that's despite guidelines and data saying don't do it. And whether this happens to you, maybe has already happened to you, is based primarily on which doctor you see. So when Chris was telling you, ask, what happens if I don't do this? That's a really important question. because you have the opportunity to stop and have a conversation with your doctor. When they say, let's get, it sounds like they're saying, let's be careful. If you ask what happens when I don't do this, and they say, well, probably nothing, but better to be on the safe side. Actually, that may not be the safe side. Getting extra tests may not be the safe thing to do. These slides will be available after, so you can see the ones that I'm skipping. Next thing I'm going to do is address whether or not the newest thing is always the best. So how many people know what telemedicine is? Anyone actually use telemedicine? Seen a doctor over the internet? Yeah, we got some people who've seen the doctor over the internet. Well, it sounds great. As a doctor, I love it. Love the idea. So as Dr. Grady said, I'm a lung doctor. And particularly, for instance, with my lung cancer patients, as they get near the end of life, it actually becomes quite difficult for them to come in and see me. And I would love it if the system were set up so that I could actually visit them over the internet, or maybe have one of their children there to show me what their house looked like, so we could talk about how to make that easier for them to use and safer. And so that they didn't have to go through using their energies at the end of life to come see me, when I'd rather have them using their energies to be with their families and do that sort of thing. So you can imagine ways in which if you're a parent and your kid is sick and there's a way you can not have to go to the emergency room on a Saturday night, awful lot of convenience benefit potential there. So you can imagine ways in which this new technology could clearly make things better. But it's also possible with new technologies that they don't, and that they might even make things worse. And so we're going to talk through what we found when, this was the brainchild of Dr. Schoenfeld sitting there, who was working with me as a medical student and got sick, and this ad popped up for him to go see, this is probably a HIPAA violation, to click here and get cured. And he came to me and he said, what do you think of all this? And he cooked up this great project that we're about to tell you about, to study these websites that put these ads out. And you can go be connected through the internet to a doctor. What you can't do with these websites is actually go and see them. And in fact, in general, you can't even at the same website see the same doctor again. There's a very common restriction. Clearly potential benefit. Most people report it's hard to get an appointment with my doctor, especially when something happens acutely. So you can see why it would be attractive to use this new technology to do this. On the other hand, you can also you don't have to be a doctor to think about how this is pretty fundamentally different than what's happened before. So how do you do a physical exam? How do you make sure that you're doing the right thing or get that information that you would need from a physical exam? How do you get a test? It's not immediately obvious. A lot of times you see the doctor and they want to get a test and it's the right thing to do. We've talked about some overuse, but a lot of times it's the right thing to do. Well, how do you make that happen? If you just connected with some doctor, you're standing here in California and you just connected with a doctor in Indiana, what are the odds the doctor in Indiana knows where to send you to get a test done here in California? Possibly not that high. And we don't have anything that looked like this before, on which we can say, oh, well, this is just a small tweak, a small change from the way we used to do it. So when you go from an emergency room to build an urgent care center that's somewhere between a primary care clinic and an emergency room, that's a small change. And you can think about, okay, well, we don't need all the resources of an emergency room, but we might want to have a little bit easier access to chest x-rays than a primary care clinic or something like that. It's more of a small change. This, I'm going to see you through your webcam, that's a pretty big change. So what we did, believe it or not, UCSF has a center to train people to fake illness. We make fake patients. We're pioneering care in fake medicine. But there's actually a good reason to do that. We historically have used those fake patients to train medical students. So we, and we're in San Francisco, we have lots of actors available. Actors slash waiters slash whatever else, Lyft drivers. And so we have taken advantage of that resource available to us in the past and trained people to present to learning situations, and act out an illness. We decided to take advantage of this to train people to fake again an illness, going to the 8 busiest of these websites that do these commercial e-visits. We wanted to play fair. So we didn't want to train people to pretend like they're having a stroke and see if the websites would mess up and not tell them to go to the emergency room. They don't advertise, come to us if you're having a heart attack or a stroke. So we didn't try to do gotcha with things they don't do. Instead, we picked 6 common illnesses that they advertise they treat. So we're going for the things they say to do, that they can do. And then we wrote the scripts for the actors so that they would line up with widely accepted treatment guidelines. So we weren't trying to test some arcane, well, I just came back from Colombia, are you going to check me for Zika virus or something like that? These are the things we'll do. Well, we'll just get into them. You'll see that they're things you've heard of. So back pain. It turns out if you're early in the course of back pain and you don't have any nerve symptoms, the thing that you should do is nothing. You should talk to the patient about rest, maybe heat and ice and stretching and exercise, but do not get an MRI or other diagnostic tests. And I'm going to walk through these 6, and some of them it was do something, and others do something down here, and other times it was do not do anything. So this one is do not order imaging. The next one, we trained women to tell the story of I had a urinary tract infection, I got antibiotics for it, I got better for a while, and then it came back. In that situation, the doctor should do something because it's possible that the woman has an infection that is resistant to antibiotics. And so you need to get a culture and see what grows and whether it's sensitive to antibiotics or not, and which antibiotics it's sensitive to. In sinusitis, you should not prescribe antibiotics. It's usually a viral thing, and antibiotics only work for bacteria, at least with the story we told. In viral sore throat, you should not prescribe antibiotics, but we decided we'd give credit if you also ordered a strep test. If your concern was, maybe I'm missing strep, someone was talking about doctors doing things to make sure that they didn't make a mistake, we gave credit. If you order the strep test, that's okay too. But if you jump right to antibiotics without the strep test, that's not correct. On the other hand, the story of streptococcal pharyngitis is a different story. The way the patient presents is different. What you would see looking at them is different. And there you are supposed to give antibiotics. So we told that story and gave credit for giving antibiotics, or if you weren't sure, taking the step of ordering a strep test. Again, that's fine. If you're going to go and confirm before you give antibiotics, that's okay. Then we told an ankle pain story where the patient had a significant injury and actually had a fracture. We don't come in and say, I have a fracture. We tell the story that a patient who doesn't know they have a fracture but does would tell. The doctor was supposed to order an ankle x-ray. So now before I get going, I want to ask you guys, how do you think people are going to perform on these? These are common things: back pain, urinary tract infection, sinus infection, sore throat, ankle pain. How many think that they'll get it right 75% or more of the time? Oh my goodness, a skeptical audience. How many think less than half the time? Oh boy. Do you think it's going to be the same for all of these? Will they? No. And which ones will they do better on and which ones will they do worse on?
They won't order tests.
They won't order tests. I hear from the front. Anyone else have thoughts? Yes?
It depends on whether it's a chronic condition or not, if it reoccurs.
So we wrote all these stories to be short term. The only slight exception to that is the urinary tract infection. She'd been treated before and it had come back, but it wasn't like years and years thing.
I would guess that they over-rely on antibiotics.
So we have a suggestion here that they would prescribe too many antibiotics. Any other thoughts? I'm really upset because my mom said this a lot. So did some of the early pay-for-performance research. And I was trying to describe it to my mother, and she was making elderberry jam, stirring this giant pot. And my mother was very much neater than I am. And she turned to me with a wooden spoon came out of the pot, and she said, "You mean they pay you to see whether or not people respond to money?" And this thing of jam fell on the floor. But she was so struck by the stupidity that I would, because I was being paid, I had to be paid to see if people responded to money, that she didn't even notice. And I was so struck that she didn't even notice that I thought, wow, what really is my research worth? Now I'm feeling it again because you guys just told me the answer before I even, why did I do this study? You got it exactly right. So here's what they did. It turned out they do some things really well. This was adherence to guidelines for 2 conditions. The strep throat, where you're supposed to prescribe antibiotics or get a test, and the back pain where you're not supposed to do anything. So if, yes, I'm supposed to give antibiotics, or I'm not supposed to order tests was the right answer, you two are both correct. They did it very well. There were some things they were terrible at. So in both the urinary tract infection and the ankle pain, where they were supposed to get tests, every single website did it right less than a third of the time. Uniformly poor performance. There were some conditions where there was variability. So in the viral pharyngitis, remember that's, and the sinusitis, these were don't give antibiotics situations. And some websites did it right a lot. But then other websites really did not do it well. And the implication from this is, or implications from this are, hey, there might be some things that this new technology is a good way to deal with those things. But there are some others where no one seems to have figured out how to use this new technology right. And then there are some where some people have figured it out, some people haven't, and they ain't talking. Does that make sense? Yes, question back there. So the question is this meant to be an alternative traditional medicine? And would insurance pay for it? The answer is that the biggest insurance companies so love this idea they've started their own versions, and that often in describing this, it is described as an alternative. So the ads for this, my favorite is sick, ? Click, period, cured, ! There's no implication there that this is anything other, that you need to lock into traditional medicine in addition to this in that ad. The ad implies click here and you will be cured. Okay? Now, when you talk to the companies that do this and some of the doctors that do this and their trade association, they say, no, we mean this to be a component of the overall healthcare system. But sometimes there are outliers to that philosophy, and then other times people say one thing when they're thinking generally, and then they make their ads a little bit different because they're trying to get people to the website.
Could you give an example of an insurance company that covers that?
Anthem and United both have their own products. They are the 2 by far largest insurers in the United States. Yes? So the comment was, so someone can prescribe antibiotics over the internet without, that doesn't seem right to me. And that's actually what happened. Do you mind if I tell them the story? So Adam's first interaction, he went to one of these websites. He went in, he signed in, filled out the form. Can I tell him what you're allergic to? Okay, he's allergic to penicillin. He filled out the form, and he noted that he was allergic to penicillin. And then he got a little web chat box pop up, and he had gone in and said that he had a sore throat. And the doctor said, I've taken the script out, but the doctor said something like, hello, what are you here for? And Adam said, thinking, didn't know, he said in the form that he was allergic to penicillin in his history and that he had a sore throat, but he wasn't sure if the doctor knew all that was in the form. So he said, I have a sore throat. And the doctor said, do you have fever? Adam said, no. And the doctor said, I'll send you a prescription for amoxicillin. That's a cousin of penicillin. And you should use some, I'm going to spell this out for you. I wish I had the slides. OTC, all capital letters, space THLENOL. THLENOL. OTC Flenol. So how many people know what to do now? OTC is over the counter, and Flenol was a typo for Tylenol. So if you look at your computer keyboard, it's one letter off the H's right below the Y. But you have a sore throat with no fever, I'll give you an antibiotic at all is bad medicine. I'll give you an antibiotic you told me you were allergic to is super bad medicine. And instructions like OTC Flenol, also pretty bad medicine. So, but we don't want to throw this baby out with the bathwater. We just have to figure out the ways to do it right. And that's what we're trying to do at the Center for Healthcare Value. So there's a lot of variation in performance. We're going to give those sites a report. We're about to publish this. Dr. Grady can tell me later tonight when that will be coming out because it's in her journal. But they have accepted it. And then as the second that it's published, we send them reports on how they did. But for you, if you do go to one of these sites, I for sure would recommend that you talk to your primary care doctor. So you go to these sites, I could imagine using them when it's convenient. You know, it's nighttime, I want to know what to do, it's hard for me to get to my doctor or something, but then loop back around, close that loop, at least for now. And especially if it's for a symptom where you wonder if there's testing, you should ask if you should have some testing. Thank you, guys. And then I just want to close with this. So what we're trying to do is we're trying to address both threats to value. Doing too much. You saw in the cataract surgery, we go out and we develop ways to figure out, even if it's a test that you can get for a bunch of other reasons where people said, oh, you can't do that. You don't, claims data, you can't do that. You just know that the test happened. You don't know why, you don't have any clinical detail. And we created pictures where we could show, you gotta be really, really skeptical not to believe those big spikes that happened in the month before aren't preoperative testing. And then we figured out ways to show who's doing it. And then we figured out ways to take away the arguments that maybe it's okay, my patients are sicker. So I hope you saw all those in that first bit of this talk. And that means you can go to them and tell a story. You can talk to them about, hey, most people aren't doing this. The data says you shouldn't do it, but we can see that you are. Can we talk about why that might be and whether or not that needs to continue? And listen to what they say. You might be wrong. You might have gotten it wrong. It is true that sometimes data don't have the detail that you need. And there might be a cataract clinic in a cardiac surgery center where they want to get all the cataracts cleaned out before surgery for some reason. And so more power to them. But I think it's fair to put the onus on them to respond to not keeping up with the guidelines, not practicing the way other people do in ways that harm patients. And it can harm you from the tests themselves. It can harm you from the answers to the tests. If you didn't need a chest x-ray and you get a chest x-ray and it shows a little spot, it's almost certainly just a scar from a prior infection, but now you got to worry, do I have cancer for the next 2 years while we follow it to decide whether or not it was cancer, just to tell you that it never was. It harms you financially. So we want to talk to them about not doing those things. At the same time, we want to talk to people about, if you're going to do something, make sure it's the most value that it can be. Don't do it wrong. We can tell. We can find ways, opportunities to do things better. We can figure out which websites are doing it better or not. We can identify situations where possibly no website could do it, at least not right now. And then we can talk, with the slide where we showed some people doing well and some people doing poorly, that's a huge opportunity to do better because obviously it's been figured out in some places. Let's get them together. So that's what we do at CHV, and I'd be happy to take your questions and comments. And for those of you who like Twitter, You can follow me there. Yes, thanks. Right, so it's possible. So the question was, what should we do in the situation where someone has a knee replacement? And the usual thing that we hope everyone's recommending is that they go to physical therapy. But it can be done, the physical therapy can be done in different ways. One way is you go to the physical therapy center and do a group class with multiple people. The more expensive way is you have a physical therapist come to your home. I think that in general, if it's an issue of patient preference and convenience, the trend in the policy-making world is to say, we'll pay the amount that would cover the group therapy at the center, and if you want the other therapy at your home, you can pay the difference. And I think that's quite possibly reasonable, as long as you make sure that when someone wants to vary from the usual for a good reason, for a better reason than I prefer it in my living room, that you build in the capacity to deal with that. I'm having trouble thinking of a great reason why someone would need you to come to their living room for physical therapy that wouldn't also make them a bad candidate for knee surgery. So if you're never going to be able to leave your house again anyway, one might argue you don't benefit much from a knee surgery, but for your specific example, I'm fumbling, but I can imagine that there would be exceptions that we would want to take into account out of fairness. Other questions? So the question was, starting with the observation, I should say, that UCSF, which has its own hospital and cancer center, but also runs a veterans hospital and provides all the faculty to the county hospital here in San Francisco, therefore provides care to people from a bunch of different contexts and with a bunch of different underlying levels of illness and particular comorbidities and so forth. For instance, veterans are much more likely than the average person to be a current or former smoker. And so given that there are these differences, is it possible to take them into account when measuring value? And I think the answer is certainly theoretically it's possible, and to what we do in trying to build performance measures, which we spend an awful lot of time on, is bring the clinicians together and ask them, what would it take for the measurement to be fair? How can we think about it, making the measurement fair? And I'll give you an example that happened here in California. When my team started a voluntary hospital public reporting program, we reported a whole bunch of different aspects of quality of care, from risk-adjusted ICU mortality to whether or not new moms learned to breastfeed before they went home, patient experience, patient survey reports, and things like that. One of the things that, and we did this, it was a voluntary thing, we tried to bring in the community to discuss it. So I set up a steering committee that had equal numbers from 4 groups. Group number 1 was the hospitals themselves and doctors. Group number 2 was insurers, because you got to have them at the table. Group number 3 were the people who pay for the insurance, the employers and labor unions and so forth. And group number 4 was consumer groups and patient groups. And the employers, labor unions, and consumers all thought that we were doing way too many C-sections and wanted to know something about it and wanted women to be able to understand their chances of having a C-section. Among that group there was some difference though. Some of the consumer people thought, well, there are women out there who want to know, they're going to help me really try to avoid having a C-section, but there are also women out there who are going to want to know, I don't want to have to beg if I want a C-section. And so while the doctors said it's really hard for C-section to be a quality measure because so many things go into it, the consumers and employers still said, well, we want to know the general tendency. Because the doctors said, could imagine situations where the patients were different. They're like, well, you know, twins, breech presentations. We went round and round in circles, not able to come to a conclusion. Until finally, it occurred to us, you know, the women don't need a specific number. They sort of want to know a general tendency. And so what we said was, what if we took all the exceptions out and just set them to the side? Excuse me. So we ended up saying, what is the C-section rate among women who it's their first pregnancy, so we don't have to worry about complications from prior pregnancies, one baby, head down, the way they're supposed to be, not breech, and they're not coming in early or with complications. They're all the way at term. So take the simplest possible case and just measure in that subpopulation so that you can communicate back to the consumer groups what is the tendency at this hospital. And in the end, they were actually all okay with that. We figured out a way through it that everyone was okay with. So the observation is maybe it's not fair to measure performance at the doctor level because so much is determined by the insurer. And I think that a fair amount is determined by the insurer, and therefore we should also measure how the insurers are doing, and that will drive them to want to help the doctors do the best possible. But the cataract study that I presented to you was one payer, Medicare, and enormous variation. So clearly the doctors contribute a lot too. I think they both contribute a lot, and the implication is we want to measure quality, cost, and value at both levels if we're going to try and build the best possible system. The last question was, you talked about, yes, you talked about the cost of pre-op tests, but what about the quality coming out? How well do patients see? We definitely, as we're moving forward, we want to measure both sides of this equation. So you could imagine value as the quality that you get for the cost that you put in. And you can't measure value if you don't have both numbers. So a really cheap cataract surgery that leaves you blind is pretty bad value. So you need to be able to measure both, and that is the goal. And as Chris was pointing out to you, Dr. Moriarty was pointing out to you, it's hard. We're still trying to figure out how to do all of that. But I hope I've convinced you that we can identify some situations where you can clearly see the variation in value, and you can even imagine things you might do about that. So thank you very much. Thanks for coming.